Hello, everyone. This is Dr. Galen Henderson of the Brigham and Women's Hospital Department of Neurology. I'm the director of the Neuroscience Intensive Care Unit, and I'm here to talk with you today regarding the treatment of intracranial hypertension. I have no industry relationships to disclose. This is the outline that I'll be going over the next 35 to 40 minutes or so. What normal is, what are some of the causes of intracranial hypertension or intracranial pressure, herniation syndromes, medical management, ICP monitoring, and eventually surgical management. In regards to some of the conditions that are associated with intracranial hypertension, we first think about mass lesions. Here are some examples of mass lesions, such as different types of cerebral hemorrhages, brain tumors or cerebral abscess, or the actual brain tissue itself swelling from these global events, such as hypoxic ischemic injury, Rye syndrome, large cerebral infarctions or hyponatremia, eclampsia, and so on. And the third category is things such as hydrocephalus itself, or typically the blockage of exit pathways for cerebrospinal fluid and the development of hydrocephalus. Those three categories are what we typically would put things into in regards to the etiologies. We know that normal intracranial pressure ranges from 3 to 15 millimeters of mercury, or 5 to 20 centimeters of water. And the dangerous thing about having ICP is when there's tissue shifting, when there's compartmentalized ICP gradients, tissue shifts, and it basically causes hypoxic ischemic injury. So blood vessels become torqued, twisted, compressed. There needs to be a higher cerebral perfusion pressure to get blood into those areas that are at risk. And so once an injury does occur, it can develop over time and become larger. So the real downside to tissue herniation is hypoxic ischemic injury. With herniation syndromes, there are multiple types of herniation syndromes. The one is discussed or talked about the most is the uncal herniation, when you see the medial temporal lobes herniating downward in this schematic, but you can have central herniation upward or downward. We can have cingulate gyrus or cephalocene herniation, listed as number 3. Transcalvarial herniation, when there has been a breach of the skull. And cerebellar herniation, either downward or upward, can be visualized. Of the clinical signs that are the most sensitive for this, I have a listing of things here, but probably the first 2 bullet points, having a depressed level of consciousness, by far is number 1, and number 2, reflex hypertension with or without bradycardia. Sometimes this may be affected by some of the beta blockade that patients may be taking. As far as the sensitivity for headache, vomiting, papilledema, cranial nerve palsies, these are things that can be seen but are quite variable. So the 2 most important things is having a depressed level of consciousness and the autonomic changes of reflex hypertension with or without bradycardia. With large hemispheric strokes, we see that in multiple small studies looking at patients, and as these patients actually had ICP monitoring as they were declining neurologically. And it showed that overall pressures were not that elevated early on, but it did eventually become high, and it does become an issue. But it is more so the tissue shifting that makes a difference, and that was probably best described by Dr. Alan Roper, published in the New England Journal of Medicine, looking at the horizontal displacement of midline structures on CAT scans and making a determination regarding the level of consciousness. Typically, when we look at CAT scans or imaging studies today, midline structures are usually measured at the septum pellucidum, but probably a much more sensitive tool would be measuring the pineal gland to see if it's shifted either to the right or left. Vertical changes did not seem to be as important as horizontal changes. We often cannot forget to make sure we look at the patient's eyes. The eyes are the windows to the soul. We do look at pupillary response, but also people must look at the retina because sometimes patients can have retinal folds, papilledema, and this is something that's important not to miss in many patient populations. Outcomes of large hemispheric infarcts. We see here, if we look at the study that's third from the bottom, the Varon-Haki study, we see that the overall mortality rate can be as high as almost 80% in neuro-ICUs with large hemispheric infarcts. So we should do more to try to save these patients or give these patients better outcomes. Some of the clinical predictors of outcomes, including age, whether there's a presence of nausea and vomiting, declining level of consciousness, pupillary dilatation, temperature on admission. So I want to say that fevers are bad. So with all types of brain injury, whether it's going to be ischemic stroke, hemorrhagic stroke, traumatic brain injury, fevers are bad. Blood pressure, NIH scores, if it's greater than 15 for the right hemispheric lesion or greater than 20 for the left, those are all associated with a poor clinical outcome. Let's review some of the anatomy of this phenomenon of increased intracranial pressure. So it all goes back to the Monroe-Kelly doctrine. And looking at the schematic to the far left, where you have the intracranial pressure of 10 millimeters of mercury, the schematic represents the brain or the cranial vault with 80% brain, 10% blood, 10% CSF. The image in the middle, if there were to be a mass lesion, we cannot change the volume of the brain tissue itself, but we can push some of the blood out from the venous side and some of the CSF out through some of the cisterns, and we can roughly accommodate that mass lesion. But if the mass lesion were to get larger, there's no accommodation of the brain tissue, very little additional accommodation for blood and CSF, and the pressure inside the cranial vault increases as a result. This hopefully explains things in a different way. If you go farther to the right with intracranial volume, we see CSF and vascular structures being affected, and overall mortality from children to adults and elderly. Elderly have more space because they have some baseline atrophies of the brain compared to a young adult or a child. With cerebral autoregulation, this is affected in patients with brain injury of various types. We live along the flat portion of this cerebral autoregulation curve. If we are to the far right, the vessels try to maximally constrict, but if the blood pressure is too high or if there's autoregulation, sometimes we can develop hypertensive changes to the far right. To the section where the curve is no longer flat and starts to go down on the left side of this curve, there's not enough perfusion pressure to keep those vessels open, and patient syncopizes and they risk having more ischemia if they're too far to the left. And what we try to do for our patient population is keep them somewhere on this flat line. We know overall the autoregulation curve for those hypertensive patients will be shifted towards the right for chronically hypertensive patients, and that in brain injury patients, instead of it being a sigmoid line, becomes more straight or just a diagonally inclined line to let you know that the brain is more so pressure passive, and we have to be careful with the overall systemic blood pressures. With general medical management of any patient, we think of these bullet points as something that happens concurrently or in parallel, not necessarily in series. So we don't do one, then the other, then the other. We think about them as being part of a collective, that all of these are addressed at every point of the patient's care. So for those patients where we have a concern regarding intracranial pressure, we do want their head of the bed elevated 15 to 30 degrees in a neutral position. And we want to avoid jugular compression, so be careful with these patients if they are intubated and the ties from the ET tube. Also, we want their heads straight, and sometimes we will put patients in a collar to keep their head from turning to the extreme right or left. We want to avoid hypotonic fluids. Even if we are resuscitating the patient, we try to avoid things like lactated ringers or other hypotonic solutions. We intubate only to protect the airway, and we do know that hyperglycemia or hypoglycemia are bad things, and we want to make sure that this is under control. I will say more regarding osmolar therapy, but if the patient were to have agitation and fevers or seizures, they definitely should be treated, because all of those can increase the likelihood of the ICP getting higher. And I'll say more about blood pressure management. For those patients who we think are failing medical management with hyperosmolar therapy, we will consider hypothermia, similar to the hypothermia that we use for cardiac arrest. We will cool the patient down to 33 degrees Celsius. Back in the old days, we used to use barbiturate therapy. And in certain cases now, we can consider decompressive hemicraniectomy. And I'll say more about those types of treatments. So in regards to the initial management, we do know that sometimes patients must be intubated, but if the patient can protect the airway, we don't intubate them just to treat them. But if that pupil blows in front of you, if you're watching the patient and the pupil dilates and is non-reactive, yes, we will intubate that patient and hyperventilate that patient, because hyperventilation will lower intracranial pressure. It is the fastest way of treating this patient. Within the matter of seconds, we can get the ICPs down. Unfortunately, this effect only lasts for about a half an hour to maybe an hour or two. So this is a temporizing measure, and prolonged hyperventilation is not considered to be effective. As we see from this schematic, as the PCO2 is elevated, the cerebral blood flow is also increases, and the ICP increases with that blood flow. Oxygen, the partial pressure of oxygen is important, but carbon dioxide is more important. With osmotherapy, this is the classic teaching, is that mannitol extracts by extracting water only from the regions of the brain where the blood-brain barrier is intact. And I do want to say, yes, you are primarily affecting the area where it is intact, and you're not affecting the area that is damaged. If it were to be a hemorrhage or an area where there's trauma, you're affecting the normal parts of the brain, not the abnormal parts of the brain. There is the potential for mannitol to accumulate and increase cerebral edema in brain injury patients, but it is not trapped there. So if it does leach into the affected areas, it leaches right out because the blood-brain barrier has been damaged. With the pharmacokinetics, the half-life of mannitol is actually quite short. And conventional teaching is that mannitol does not cross the blood-brain barrier, but labeled mannitol does enter the CSF under normal conditions, just a little bit. The effects of mannitol are listed here, and the overall concern has been that it would cause renal failure. So people typically would follow the number of osms, and if the osms are greater than 315, 320 or so, they would stop. We do not recommend this therapy because even though that is something that we were taught, we can't really find this validated within the literature of where that actually comes from. So what we typically do at our institution is that we follow the osmolar gap. So this is a protocol that we use that you see before you. We send a sample of blood to the lab, and then we perform a calculation by hand, and you see the equation in the bottom left of this slide. We get a number back from the lab, and then we subtract the hand calculated number, which is usually less. If the gap is greater than 10 or so, we know that this patient has retained mannitol in their system, and we will not give additional mannitol. If it is less than 10, we will treat that patient and with that particular agent. So this, we think, is a more effective way of using mannitol. And sometimes we do have patients with osms greater than 310, 315, 320, 350. We don't pay as much attention. We don't use that as the limit to whether or not we treat people with mannitol. It is the osmolar gap. Other osmolar agents that can be used include hypertonic saline. And hypertonic saline is a wonderful agent. With this compound, the downside is that it is not standardized in regards to its concentration. We know that plasma osmolality has osms of 285. 25% mannitol is 1,375. And 23.4% normal saline, or hypertonic saline, is 8,008. With this 23.4% concentration, it only comes in aliquots of about 30 milliliters. It must be given centrally. So in many institutions for the treatment of adult patients, we can use 3%, 7%, 14%, and it varies from institution to institution as far as what the standards are. I would say that any concentration greater than 14% probably should be given through central access, which means a central line or an interosseous. With hyperosmolar therapy, here are the potential pros and cons. People do think of whether or not patients may develop central pontine myelinolysis from the sudden change of sodium. Even though this drug has been around for a long time and used in thousands of patients, there is not one case report discussing central pontine myelinolysis in a patient who was treated with hypertonic saline. It's been shown that in trauma patients, it is just as good, and in some cases, possibly better than mannitol, especially in TBI patients. And here is just one of many trials looking at hypertonic saline versus mannitol solutions and the overall effectiveness of drugs. As I said before, fevers are bad, and for every centigrade rise in temperature, the risk of a poor outcome doubles. And this goes for all types of brain injury: ischemic stroke, hemorrhagic stroke, traumatic brain injury. Fevers should be treated with antipyretics or devices, meaning they should have cooling blankets, or they should be on normal thermia protocols. Hypothermia has shown to be effective in animal studies because fever promotes the release of neurotransmitters of neurotoxic injuries such as glutamate and glycine. There's an increase in free radical production with fevers, as well as continued effect of the blood-brain barrier and acceleration of the breakdown of nerve cells cytoskeleton. The temperature in the injured brain may exceed core temperatures by 2 degrees Celsius. So if your patient has a fever of 102, 101 Fahrenheit, the brain temperature can be 2 degrees centigrade higher. For those patients, as I said, that are resistant to treatment, or you're running out of options, back in the old days, we used to give people pentabarb to put them in a pentabarb coma, because this lowers the metabolic rate of the brain and basically puts the brain to sleep. And when we do this, we typically will have bedside EEG monitoring, because the goal is to have a virtually flat EEG. The downside is that in using this drug, more than 50% of the patients will need pressors, because this drug does cause myocardial depression, hypothermia. You may be getting increased risk for overall infections, and many of these patients need to be on inotropic agents to maintain their blood pressure. In regards to aggressive treatments, we do think about whether or not which patients should have intracranial pressure monitoring. But overall, it's those patients that we are being aggressive about, and it is a case-by-case basis. For those patients that have intracranial pressure monitors, we consider ventricular catheters to be the gold standard. They are accurate and reliable. You can drain CSF, meaning you can treat intracranial pressure, and also have a number to measure. For other types of monitors, such as parenchymal monitors, another name for that is a bolt. They are easily placed, low infection rates, and after about 4 or 5 days, the number drifts several points and are not as accurate. They can be re-zeroed once they have been placed into the brain. Epidural bolts and subdural bolts are not as accurate, but they are used in patients sometimes if there is a extreme coagulopathy, and the others are not as safe for those types of patients with bleeding dyscrasias. Picture of what a bolt looks like. And the catheter that you see, fiber optic catheter, goes in through the butt of the wing nut. And here's a picture of the tip of an external ventricular drain. You see the holes. There are holes all around this small catheter as well. So you can drain CSF. This is the waveform that we typically will see in patients with intracranial pressure monitors: P1, P2, and P3. P2 is usually 80% of P1. P1 represents the percussion wave, or the systolic bump. P2 is the tidal wave and reflects the brain compliance. And P3 is the dichrotic notch, which reflects the aortic valve closure. When we see P1, P2, and P3, like this top image, when we see P2 elevated like this, we say that there is poor compliance. We know this patient is not doing well. The image towards the bottom of the slide are patients that have a dampened waveform either due to bubbles or brain material clotting off the catheter itself. Going from a normal waveform with no cerebral lesion with the schematic, go to the far right and up, we see a lesion develop in the middle and the lesion growing in size to the far right. And we see the change in the intracranial compliance curves. Give you an example of how we manage blood pressure and intracranial issues. So this is the equations. The cerebral perfusion pressure is equal to the mean arterial pressure minus the ICP. So if the CPP is 40, we can possibly control the MAP, and we see the ICP is also 40. It's also very high. So we can CPP optimization, so we consider a pressor. And here are the choices that we typically use. We tend to use probably a little bit more neosynephrine, but the downside with neosynephrine is that the heart rate can be blunted as a result. Every medicine has its pros and cons. For patient number 2, cerebral perfusion pressure is equal to the MAP minus the ICP. So if the cerebral perfusion pressure is 80, we can possibly change the MAPs, and if the ICP is 40, osmotherapy is the way we want to handle this with mannitol or hypotonic saline, or possibly hyperventilation. With patient number 3, we have CPP is 110. We can possibly change the MAP, and the ICP is 40. We consider lowering of the MAPs for this patient. And of the ones that we use here, we probably use calcium channel blockers, nicardipine, because it is safe and very predictable. Nitrates, such as nitroprusside, very inexpensive drug, but all over the place in regards to blood pressure control. Many more nursing hours are spent trying to control blood pressure with that agent compared to nicardipine. Sometimes for those agitated patients, we have to sedate them. We do like propofol for this patient population because we can stop the drug and perform a clinical exam. So the agents that we're using are shorter acting agents. Trial of intracranial pressure monitoring in traumatic brain injury. This was a randomized trial with over 300 patients with severe TBI, so their Glasgow Coma scores were 8 or less in Bolivia and Ecuador. They used standardized guidelines. With intracranial pressure monitoring was not superior to the management based on imaging and clinical assessment. And when we look at overall ICP treatments, we see serious adverse events in both groups. So for patients with severe traumatic brain injury, care focused on monitoring intracranial pressure at 20 or less and was not shown to be superior to the care based on imaging and clinical examination. There is another study expected to be out soon or published soon with a higher mark for intracranial pressure of 25. Even though this is a higher mark, we don't expect the results to be that much different, but time will tell and we will see when the study is announced. Surgical management of compartment syndromes. Our compartments include the cranium, chest, pericardium, limb, and abdomen. Pathophysiology you see listed here. For the cranium, you have increased intracranial pressure. Chest, you have temperature pneumothoraxes. Pericardium, cardiac tamponade. With the limbs, you can have extremity compartment syndrome. And there are surgical managements for all of these cases. The evidence for surgical decompression for intracranial pressure really comes with ischemic stroke patients. And this was published back in 2007 in Lancet Neurology, where they looked at 3 trials, collected the data from the Decimal, Destiny, and Hamlet trials, and they looked at overall outcomes. The patients who were involved with these large strokes were ages 18 to 60, had space-occupying lesions, and they were treated within 48 hours of stroke onset. And they looked at modified Rankins at 1 year and said that a favorable outcome was a score of 0 to 4, and unfavorable was 5 and death. Secondary outcome measures were also obtained. Findings showed that in 93 patients, more patients with decompressive surgery than in the control group had a modified Rankin of 4 or less. And some had modified Rankins of less than 3. 78% survived, the ones with surgery, compared to 29% who did not have surgery. Number needed to treat for survival was 2, and modified Rankin was less than 4. 4 patients for survival with modified Rankin, number needed to treat 4 for survivals of modified Rankin less than 3. So this does show that there is benefit in surgical decompression. In patients with malignant MCA infarctions, decompressive surgery undertaken within 48 hours of stroke onset reduces mortality and increases the number of patients in with a favorable functional outcome. The decision to perform decompressive surgery should, however, be made on an individual basis in every patient. Even in older patients, meaning above age 60, this was performed and did show that these patients also benefited. The majority of survivors had substantial disability and required assistance with most bodily needs, but they were alive. So it did improve survival. Looking at survival curves. And there was another very important trial called the DECRA trial, decompression of craniectomy and diffuse traumatic brain injury. Even though with this trial there was a decompression and the ICPs were normalized, these patients did not do well. Their outcomes were actually clinically worse. Now, I do want to say that the way the decompression occurred was typically not done in the traditional fashion of surgical decompressions, because in North America, we tend to decompress one side of the hemisphere or the other. In this particular trial, it was a bifrontal temporal approach, a modified Poulin procedure. But with that approach, the ICPs did go down tremendously. I'll give an example of a surgical decompression where the bone is removed and the brain is allowed to herniate outward. And a number of weeks later, we can replace the bone, or if the bone is infected, we can throw that out and have a bioprosthetic placed. We have a CAT scan image of the skull, a 3D image of the skull. We can send it to certain companies and they will produce this bioprosthetic, and it can be placed onto the skull like a fitted glove. General medical management, as I said before, head of the bed elevated 15 to 30 degrees, avoiding jugular compression. And sometimes people will place central lines instead of placing internal jugular artery catheters. They will place subclavian catheters to avoid any possibility of affecting the jugular outflow or venous outflow from the skull. We'll avoid hypertonic solutions, intubate only to protect the airway, hyperventilate if necessary, and we discuss cases of blood pressure management. So we talked about issues of normal intracranial pressure, some of the causes. We reviewed herniation syndromes, the medical management, ICP monitoring, and surgical management. We also discussed issues of hypothermia for the treatment of intracranial hypertension and surgical decompression. Thank you very much. This is Dr. Galen Henderson of the Brigham and Women's Hospital Department of Neurology, Division of Neurocritical Care. Question number 1. Which is the most reliable intracranial pressure monitor? A, ventricular catheter, B, parenchymal monitors, C, epidural bolts, D, subarachnoid bolts, E, lumbar drain. The correct response is A. Ventricular catheter is the most important, most effective way of treating intracranial hypertension, or is we can treat the patient by draining CSF. We can also measure the patient's intracranial pressure. Question number 2. Which patient should be considered for ICP monitoring? A patient at risk for elevated ICP. B, a large hemispheric stroke with early swelling. C, large hematoma with brain shift. D, Glasgow Coma scale of 9 or less. E, all of the above. The correct response is E. This is something that should be considered in all patients who may qualify. Question number 3. Which is the most rapid maneuver to lower intracranial hypertension? A, head of the bed elevated 15 to 30 degrees in a neutral position, avoiding jugular compression. B, avoiding hypertonic fluids. C, hyperventilation. D, glucose management. E, osmolotherapy. The correct response is C. 4. Which is the most sensitive clinical sign for intracranial hypertension? A, depressed levels of consciousness. B, reflex hypertension with bradycardia. C, headache. D, vomiting. E, none of these above. The correct response is A. Question number 5. Which patient below has the most significantly impaired quality of life after stroke? A, younger age. B, less comorbidities. C, cerebellar strokes. D, right hemispheric strokes. E, left hemisphere strokes. The correct response is D, right hemispheric strokes. They have less quality of life.